Well, this is my version of a face mask. I say we go to this model instead of the ones we're using. So actually, this is probably the first grand rounds in the history of medicine to be introduced from a deer stand, and I'm okay with that. Dr. Law earned his bachelor's in biomedical engineering from the University of Iowa, then his MD from the University of Iowa College of Medicine. His PEDS residency, pediatric cardiology fellowship, and electrophysiology fellowship were then earned from the University of Michigan Medical Center in Ann Arbor. He came up through the ranks, and he is currently the director of the Division of Pediatric Cardiology, University of Iowa, Carver College of Medicine in Iowa City. I actually interviewed there in the 90s for a fellowship and was just humbled by the legends I met there. And Dr. Law is now one of those, even more so. His list of research and teaching, publications, leadership would take up the whole hour to list. So we've been having an EP outreach clinic at Sanford Children's for since the early 2000s, and we've been taking care of patients since then. He is our partner in taking care of kids and adults with congenital heart disease and electrophysiology issues. Long story short, by God's grace, I found out Say again? Long story short, by God's grace, I found out my firstborn had WPW, World Parkinson White, and was at high risk for sudden cardiac death. It was Ian that I called for help, and he made a special trip to protect my child. I trusted him with my child's life, and I consider him a friend. Please give your full attention to Dr. Law as he discusses the heartbreak of COVID-19 across age, evaluation, management, and return to play. Thank you.
Thanks, Bill. I was just going to check your eyesight. So I've got these antlers on, but these are not anything you'd shoot at because I'm not a real deer because these are plaid. So
you know, you're lucky you're out of range though.
I'm pretty fast. Well, thank you very much, Bill, for your kind words. And it's been a great partnership working with the group up in Sanford over the years. As a cardiologist in Iowa, I received numerous calls about returning to play and COVID in the heart. So I thought I'd give what I've learned over the years, over the months, about this very timely topic. So first off, I have no disclosures. However, as we all know, there's been a tidal wave of information about the COVID pandemic. And early on in May and June, there were about 5,000 research papers per week appearing. And so my disclosure actually is that this data may be obsolete by next week because I am constantly reviewing the literature and trying to keep up with what the most latest and greatest diagnostic tests are and treatment strategies are. So this is a quick background about the COVID life cycle. And as we know, the ACE2 receptor is the receptor that allows the COVID virus to get into the cell and then, of course, is replicated and put back out in the body, which is what promotes the disease process. However, we used to think this was the case, but now we know that neuropilin is another receptor on the human cells, and this research just came out October 21st, so within the last week and a half. Now, new research, COVID-19 is able to use a receptor called neuropilin, which is very abundant in human tissues, including respiratory tract, blood vessels, and neurons. This was an interesting article, and they used a supercomputer to analyze the genetic material of thousands and thousands of people. And what they found out is that this histamine bradykinin hypothesis is that it just wreaks havoc in the body. And this is COVID-19 is like a burglar who slips into an unlocked second floor window and starts to ransack the house. Once inside, though, they don't just take your stuff, they also throw open all the doors and windows so their accomplices can rush in and pillage even more efficiently. So this is a timeline. This will be appropriate throughout the talk of when we're talking about our testing for disease here. So if you look at the red bar here, this is 0, 1 week, 2 weeks, 3 weeks from the week of infection. And we know that the antigen level increases. And by the time you get to 1 week, we're up. And this is when we start doing our testing typically because the symptoms come on about 4 to 5 days. we get this peak of antigen that comes up, and then we start getting our antibodies that kick in, and here's IgM, and here's IgA, and here's IgG, and they come over time. So this is what initially we test for this with our antigen testing, and we verify it often with a PCR test, and then we go for antibody. Antibody testing is not quite as prevalent now, but I think it soon will be. So how does the COVID affect the heart? As we said, it typically goes into the lungs, and once it gets into the lungs, it can go anywhere in the body. But when it gets into the lungs, the decreased oxygen supply can cause what's called a type 2 myocardial infarction. You can also have direct invasion into the heart, although as we'll point out, this is fairly unusual. Other effects on the heart can be just the stress of the disease itself. The sepsis-like picture that can develop can put stress on the heart and cause a cardiomyopathy. You can get an inflammatory response within the heart. You can actually have plaque rupture, a type 1. You can also get thrombosis. We know that COVID is thrombogenic. And then also you can get this microvascular dysfunction. So all these things are effects of COVID on the heart. Now, early on in Wuhan, China, they reported that cardiac injury, and this cardiac injury was based upon a rise in troponin over the 99th percentile, occurred in about 20% of patients. And then if you had COVID effects in the heart, the mortality rate was 50% versus about 4.5 if you didn't have cardiac involvement. So they realized early on that when COVID affects the heart, it's can be extremely detrimental. And then another study came out not too long after that saying, well, it's not 20%, it may be as high as 30% that are affected by COVID. And the death rate, the mortality rate is 60% if you have COVID effects on the heart versus 10%. And then even later on in the game, they found in the German study that in patients who had recovered from a COVID infection, they did MRIs at an average of 71 days out, and they found that 80% of the patients were found to have COVID effects on the heart. So the slide over here just shows you if you have COVID infection in the heart as determined by a rise in troponin, your mortality rate is much higher than if you don't. And this is based upon the German study, 78% had some COVID effects on the heart versus those that didn't. So this is looking at the troponin, because the troponin is one of the key biomarkers of COVID infection of the heart. So if you have an increased concentration of troponin, it causes myocardial injury as a side of myocardial injury. Now, it could be that you've got a rise in troponin because you've got this chronic congestive heart failure. Because if you have chronic congestive heart failure, you'll have this kind of smoldering rise in your troponin. And that can be from congestive heart failure, cardiomyopathies, hypertension, kidney disease. And then you can also have myocardial injury that's not ischemic in nature. We talked about this earlier. It could be from myocarditis, stress, acute heart failure, or sepsis that puts a stress on the heart, pulmonary embolus, critical illness. So these are myocardial injury, not due to direct injury in the heart, but due to secondary effects. And then you can also have the type 1 myocardial infarction from atherosclerotic plaque disruption or respiratory failure, hypoxia, tachyarrhythmias, and hypertension. All of these will cause a rise in troponin. Now the question is, what is troponin, right? We order it, and a lot of us probably know this, but just to update you guys, troponin is that you've got your myosin rod and your actin, and troponin is on this actin filament, and it's a portion of it. This is the troponin T, which you typically test for. Now, troponin, every troponin test is not the same, and you'll read in articles, the literature, and you'll see that some will report it in picograms, some will report it in nanograms. Iowa uses this high-sensitive troponin. These are all the high-sensitive. Back in the 90s, we had this kind of low-sensitive troponin. Here we use high-sensitive troponin right here. There's even more highly sensitive troponins, and so if you read the literature, you have to be careful about what you're comparing. So this is the one we're looking at, and our troponin cutoff right here is 0.1 nanograms. So this is where I was referring to earlier. When you check a troponin, if someone has congestive heart failure, you may have this kind of smoldering rise. Here's 0.01, here's 0.1, where they kind of skirt that border of what we consider an abnormal troponin level or above the 99th percentile. If you have an infarct, what you'll see, here's day 1, here's day 2, here's day 3, you'll have this acute rise, and it keeps on going up at day 1, and then it starts dropping off again. You can see this rise is much greater than that kind of smoldering congestive heart failure. So this goes over and tells you about that a rise in troponin can be secondary ischemia, inflammatory processes, congestive heart failure on top of COVID infection, on top of congestive heart failure. And then you can have non-cardiac reasons, which is the pulmonary embolus, renal failure, sepsis, burns, and extreme exertion like marathons. And this is an example. If you check a troponin on marathon runners, this is within a day, you can see acutely after a marathon, you have this rise in troponin that drops off over the next 48 hours. And I've run a couple marathons, and I'm glad I didn't check my troponin because I'm sure mine was sky high. Once again, if you have a STEMI, ST elevation myocardial infarction, you have this acute rise, but you can have these other myocarditis that are very similar to levels you'd see in a marathon runner. Now, looking at troponin levels as a marker of survival, you can see that, and this is based upon one of the studies in Wuhan, China, that these people that have these low-level troponins do much better than these that have, after a week, continue to see this rise. And once you get up in this, by day 22, if your troponin is still going up, your mortality rate is incredibly high. And here's another study showing the same thing, that if you look at the mortality rate based upon just your troponin level, that the higher the troponin level, the higher the mortality rate. So take-home point here is, if you have an increased troponin, think about cardiac disease. If you have a very high troponin level, you have a much worse prognosis. So there's been a lot of talk about myocarditis and COVID, and the diagnosis of myocarditis is often thrown around, and we use it. I mean, we're all as cardiologists guilty of this, saying that, well, they've got myocarditis. Well, it's actually, myocarditis and COVID is actually quite rare, and it's been assumed not based upon confirmatory tests. It's probably this 7% is only probably even an overestimate. In order to make the diagnosis of myocarditis, first you have to have histologic findings. You have increased lymphocytes, myocyte necrosis, not typical of ischemia. You have to do genetic testing on the heart and find that you've got the COVID-19 virus within the heart. And then you want to see the viral particles within the cardiac myocytes. And then you have to make sure that there's not another known virus, such as an enterovirus or parvovirus within the heart. So when you look at the strictest of diagnoses, myocarditis and COVID-19 is actually fairly rare. And there's an article that just came out. This goes along with that tsunami of COVID reports, that this just came out in late October, saying that myocarditis is rare, and they think it's actually much less than 2% for COVID, a true COVID myocarditis. So what we typically see is probably myocardial inflammation, not myocarditis. So if you have myocarditis, you'll have myocardial inflammation. But if you have myocardial inflammation, it doesn't necessarily mean you have myocarditis. Myocarditis is in the subset of all those patients that have myocardial inflammation. The diagnosis of myocarditis cannot be based only upon the troponin elevation, and additional evidence is often lacking in these studies. So now we know that a rise in troponin is a marker of a bad prognostic factor in COVID. And we know that the COVID infections that involve the heart is bad, but let's look at it out of hospital arrests in Denver. And so this is the secondary effects, or perhaps primary effects. And what they did is in Denver, in Colorado, they looked at out of hospital arrests and EMS runs. And this is before we had the mandate and the basic stay-at-home order. This is around the time of the mandate, and this is after the stay-at-home order mandate in March. And what they looked at is, here's cardiac arrest, and this was kind of a chronic. This is over the years, how many people had cardiac arrest. This is the EMS runs. And what you noticed is, once they had that post-mandate, the EMS runs dropped off dramatically, and that of hospital cardiac arrest went up. And this is just another marker of that over the years. And then here you see in 2020, a huge rise. So the question is, why is that? And it's possible that the complications of COVID are responsible for these out-of-hospital cardiac arrests, or it's possible that patients with acute coronary syndromes are not presenting for care, resulting in an increase in out-of-hospital cardiac arrest. And so this is one of those secondary effects, and we've seen this across all diseases, that COVID has caused us not to go into the hospital, and it's an effect of COVID regardless. So if we look at the effects of COVID on the heart, and one of the main cause of death is typically arrhythmias, or even if you had progression of your heart failure, you often end up with a arrhythmia that is your ultimate demise. So the arrhythmias that are associated with COVID include supraventricular tachycardia, atrial fibrillation, atrial flutter, and what you see a lot of these are atrial driven. Then you have these polymorphic VTs. What are the potential mechanisms? Hypoxia, myocarditis, and we say myocarditis is probably myocardial inflammation, abnormal immune response, myocardial ischemia. And actually, early on, there was a big concern about drug effects and hydroxychloroquine causing arrhythmias. The management strategies are, as we do with everyone, supportive care. But you want to try to avoid medications that can prolong your QT interval. And of course, optimizing management by doing procedures on those that aren't at high risk from COVID infections. So if you looked at a study out of New York, they looked at those that survived and those that didn't survive that had COVID, and those that didn't survive had more premature atrial complexes, more interventricular conduction delay, abnormal QRS axis, myocardial infarction changes, T-wave inversion. These were the most significant changes. What's interesting about this is you don't see ventricular arrhythmias and PVCs as a marker. It's actually atrial arrhythmias that are causing the problem here. Some had AV block, some had signs of LVH and RVH, and some non-specific repolarization in AFib. Heart rate, QTC, PVCs, and SC elevation in this population did not predict those who were survivors versus non-survivors. Now, when you look at this list here of what are the markers of COVID effects on the heart and poor prognosis, there's an overlap between that and the normal athlete variant. So when you say, okay, let's try to determine if an athlete is at high risk because they've got a COVID infection. Well, if you look at left axis deviation, right axis deviation, T-wave inversion, these are findings we can see in athletes that, if in isolation, point you towards a normal variant. These are all normal variants in athletes. These are red flags. If you have two or more of these, it's a concerning finding in an athlete, but just one of these, which is actually on this list, can be a normal variant. So as we evaluate our athletes who've had COVID infections, we have to be cautious. This is the patient that actually, this is an ironic story. This family lived in New York, and to escape the pandemic, they came out to Iowa. They came out to Iowa, and the girl got COVID. And so this was her EKG, and what you can see here is she's got these P waves that are marching through. She had this atrial tachycardia, and there's a P wave there, there's a P wave there, there's a P wave there. And she was kind of in this incessant tachycardia, go, and then it'd stop, and it'd go back and stop again. And the family said, we're gonna drive back to New York. And I said, well, I don't think you can drive back until you get this under better control. And this became more incessant, and we ended up putting her on amiodarone and flecainide before she went back, and then eventually this calmed down. And I'm not sure what happened to her after she got back to New York. These are your typical ST segment elevations that you may see in a patient who's got myocarditis. So obviously, I don't think any one of us would look at this and say, I'm not going to worry about this, but this is what you might see. So with regard to echocardiogram, this is a study done in Tel Aviv. They looked at 100 hospitalized patients, and they tried to risk stratify those that had deterioration, those that didn't. And clinical deterioration occurred in 20% of the patients, and right ventricular dysfunction was much more common than left ventricular dysfunction. So 32% had a normal echo, 39% had RV dilation dysfunction. LV dilation dysfunction was much less common, and some of them actually had valve involvement. So as I'm going to give some examples of what you might see on an echocardiogram, and this is what's called the peristernal long axis view. So you'll go with the heart like this. Here's the left atrium, left ventricle, aorta, and here you can see this dilated LV. which was less commonly seen in myocarditis. And here's a short axis view where here's the left ventricle and here's a right ventricle. This would be a normal short axis view where there's our right ventricle, here's left ventricle. And here's a patient who's got this very dilated right ventricle that you might see in COVID myocarditis or myocardial inflammation. Here's another view of the heart, and this shows not only dilation, but a much decreased ventricular squeeze, left ventricular ejection fraction associated with the myocarditis. So in Germany, they also looked at MRIs. This is that study I talked about early on, and they had 100 patients that had COVID infections. And they, when they did this study, they compared those patients who had COVID that were hospitalized and those that never required hospitalization. And they compared those to healthy controls and those that had risk factor match controls. So you can imagine if someone has smoldering congestive heart failure that doesn't have COVID, they might have an abnormal cardiac MRI, they might have an abnormal troponin. If they have diabetes, if they have, kidney disease. So what they did is they said, okay, let's compare patients who were hospitalized versus those who had COVID, who weren't hospitalized, so those that had risk factors that were similar to those who were healthy. And what you see is, baseline, there are some healthy controls that may have elevated troponins. Maybe these guys were all marathon runners, who knows? These guys had elevated troponins, as you might suspect, for someone who's got risk factors. And then here you look at those and you look at the average troponin of those that were hospitalized versus those that weren't, and you see that there's an elevation troponin, and this goes along with the data we've talked about before. And then you look at T1 and T2. These are findings that you see on MRI. T2 changes are a sign of edema, and T1 is extracellular volume and fibrosis. And T1, there's a significant difference in those that were hospitalized versus the non-hospitalized in their T1 findings. And these MRIs were done at an average of 71 days out. Sorry about that. So these people have been hospitalized or not hospitalized, had COVID infection, and they got their MRIs more than 2 months later and still had these MRI findings. And these are what we might see on the cardiac MRI in this top view. And this is where it's the voodoo of cardiac MRI. Our imaging people just, salivate when this is. And I'm like, I'm not sure what I'm seeing here. But they actually will draw an area and they'll look at the density or the pixel comparison between this and the normal cardiac tissue to compare T1 and T2. And the bottom, what you see here is these yellow arrows are pointing to in a pericardial effusion right there. And then the white arrows are actually pointing to epicardial enhancement, late gadolinium enhancement, which would suggest scarring right here. So effusion, scarring, these are both patients that had COVID. In the study by Putnam, this was one interesting finding there, is that adult male with myocardial inflammation. Now, once again, they didn't say myocarditis, they had myocardial inflammation. It had minimal symptoms. Early on, he had loss of taste and smell. He had a mildly increased temperature, no previous conditions, and didn't use regular medications. And they did a cardiac MRI in him, and it's markedly abnormal. So minimum symptoms, markedly abnormal cardiac MRI. And they did a biopsy, and you can see he had COVID within the heart. Now, it's not within the cardiac myocytes, it's outside the cardiac myocytes, which is why they called it myocardial inflammation, not necessarily myocarditis. So minimum symptoms, still had cardiac findings by MRI. This is another study done out of China. And once again, this was I put this up to illustrate what you might see on cardiac MRI. And here you can see the LV, and here is this area right here that has been picked up by cardiac MRI as an area of cardiac involvement. Same thing here, you can see this thin kind of lighter rim right here. And this is what, when you trace, you're looking for these areas right here, and here's another little area right here. This is where I'm thinking, you gotta be smoking what they're smoking to see that, because I'm not gonna pick up that, I don't think. So cardiac involvement by cardiac MRI was seen in almost 80% of COVID patients. Once again, this was about 2 months out. And ongoing myocardial inflammation was in 60%. So This 78% was both T1 and T2 changes, as well as late gadolinium enhancement, which is a scar-related issue. Myocardial inflammation was independent of a pre-existing condition, severity of disease course, overall course of the acute illness, and time from the original diagnosis. So the T2 changes were seen regardless of whether you're hospitalized or not hospitalized. T1 changes were more significant in those that were hospitalized. And so I thought I'd give some examples of what we'd see on a cardiac MRI. This is what we're looking at from the heart standpoint. And if I just play this here, you'll see this is the left ventricle here. And this is markedly dilated, poorly squeezing, poor function in LV. And given the changes that we see in COVID, the several groups have come out with things, guidelines to say if you're going to get a cardiac MRI on someone who's had COVID, these are the things that you need to really watch out for. You need to get the T2 weighted sequences, these certain parameters, because these are the markers that are going to help us determine who's got cardiac disease if you've had a COVID exposure. Now, what's interesting about, we talked about EKG changes in athletes and how there's an overlap of what you might see in an athlete and in someone who might have had COVID exposure. The same thing happens with when you're looking at cardiac MRI. And so this is cardiac MRI data on both men and women. And these are the non-athletes. These are your regular athletes, and these are your elite athletes. And what you notice is we'll just look at LV volumes and RV volumes here, right? So here's an LV volume in a male. Their index volume is about 100 cc's per meter squared. If you're a regular athlete, you have a more dilated heart. If you're an extreme athlete, you have even more dilated heart. And the same can be said for right ventricles. The right ventricle at baseline, if you're a regular athlete, and if you're an elite athlete. So once again, the findings we're seeing in COVID also overlap with the findings we see in athletes. And so as we try to risk stratify athletes, we're going to have a little bit of a problem with that. So I thought I might just briefly discuss what treatment do we have for COVID infections in the heart? And the answer is we don't have the answer. So if you look at myocarditis, and this is based upon the European Society for Cardiology, for myocarditis, there's no clear recommendations for the treatment of myocarditis secondary to COVID, other than our regular treatment strategies. And if you have a treatment with a SARS infection, you've got cardiac involvement, that may not be myocarditis, there's a scarcity of evidence regarding the efficacy and risk of different treatment strategies. So essentially, this is an evolving process. And whatever the reasons for the apparent decline in mortality, move my little box here, the impact of the drug treatment in COVID-19 pandemic is still limited. The massive research effort needs to bear fruit with a broader range of effective therapies. So we are still trying to figure out how to treat the cardiac effects from COVID. So we're going to switch gears from pediatric to adult, sorry, from adult to pediatrics, to see what effects COVID has in the pediatric population. And the good news is in pediatrics, less than 10% have more than moderate symptoms. But there are cases of multi-organ involvement, and the fatality rate in pediatrics, now this is a little bit older data, but the current fatality rate at the time, when this was about a month ago, was 3% in adults and pediatrics. So when I talk about fatality rate, that's the number of deaths in that population versus the number of cases. When you look at mortality rate, we're looking at the number of deaths versus the entire population. So if we say the mortality rate for an MI is, 2%, that means the number of deaths over the whole population, not just those that have cardiac disease. So this is the number of deaths in pediatrics versus the number of cases, and that's 0.02%. The clinical manifestations in pediatrics of COVID infections are different. They often have more respiratory, but also more GI symptoms. The risk factors in pediatrics are obesity, severe lung disease. There are some other risk factors, but these have come out in the larger studies as more consistent. But what we're most worried about in pediatrics is just multi-inflammatory syndrome in children. So when we look at the death rate, and this came out about a month ago, they said, oh, there's this remarkable increase in the number of cases in pediatrics, the number of hospitalizations in pediatrics, and the number of deaths, which by these graphs are really quite remarkable. But when you look at the total number of deaths associated with COVID was really quite low. And so a small change makes a big difference. And when we look at the total deaths in children versus the total COVID deaths, children make up about a little less than 0.1% of all the deaths, COVID deaths, and their overall mortality or fatality rate is 0.02%. So it is fortunately quite rare for children to succumb to the COVID infections. Now, with regard to the multi-inflammatory syndrome in children, how do you make the diagnosis? The diagnosis is made on people that are under 21 years of age. You have to have a fever. You have to have laboratory evidence of inflammation and evidence of severe illness with greater than 2 organs involved, and these are the organ systems that can typically be involved. You have to have no other plausible diagnosis, and you have to obviously be positive for the SARS virus. And actually, typically, the multi-inflammatory syndrome in children the syndrome occurs about 4 weeks after the COVID infection and symptoms. You also have to look for Kawasaki-like changes. But there's a difference between this multi-inflammatory syndrome in children and Kawasaki's disease. This is a great chart that was published in Pediatrics. The age of multi-inflammatory syndrome in children is much older than that than we see in Kawasaki's. We're looking at 10, 11-year-olds versus an average age of 2. These children typically have more abdominal pain. They have more myocardial dysfunction. So in Kawasaki's, we see more cardiac coronary artery involvement here, 25 to 60%. This is more myocardial dysfunction. We see a rise in pro-BNP and troponin. Here we see other markers such as CRP rise and ESR. Platelet counts in MISC are usually decreased, whereas in Kawasaki's disease, we actually see thrombocytosis. So these are the things we're looking for. Even though we think of the two diseases as similar, there are dramatic differences in their biomarkers and presentation. This is a study published in the New England Journal of Medicine. We looked at 186 patients, average age was 8.3, that had multi-inflammatory syndrome. And the majority had been previously healthy. Almost 90% required hospitalization. And most of them were hospitalized for at least 7 days. 2% died in this. And what you see here is this is a little bit different than adults. The BNP was more often elevated than the troponin. So in troponin, the troponin is a much better marker for an adult, but in pediatrics, the BNP was a better marker. And this just looks at the echocardiographic changes that took place. And the majority had echoes performed, and the EF was preserved in the majority of those patients. So of 91 patients, the EF was normal. Left ventricular ejection fraction was normal in 62%. Arrhythmias were rare. ECMO was rare. And these are some of the findings that you can see in cardiac MRIs in these patients. This was a study done out of New York, and they had 32 cases, 9 of which had suspected myocarditis. The 5 oldest ones underwent cardiac MRIs. They did not do cardiac MRIs on the younger ones because they didn't want to have to intubate them for the procedure. But what you'll see is here's the LV wall, and here you can see this light area, which is a sign of enhancement on the T2 and T1 changes. These are T2 changes here, which is edema. Here's some T1 changes. You know, I had a tough time when I looked at this to see what the changes were, but apparently they're there. This is why you have cardiac imaging specialists. And then here's some areas down here with a late gadolinium enhancement scar there. And this is another recent study that came out. This was a retrospective review of 28 patients that had multi-inflammatory syndrome versus 28 patients that had classic Kawasaki versus 20 controls, and looking at the echo changes. And what they found was that coronary artery injury was very rare, which once again, we found that out with the New England Journal of Medicine study. But myocardial injury was relatively common. And in follow-up, RV changes were more prevalent, and diastolic changes, RV changes were seen early on as well as LV changes. But in follow-up, even though their LV was squeezing more normally, that there's still diastolic dysfunction. So there's still some ongoing changes that we see long-term. And this goes back to what we saw in the German study, that even 2 months out, we're still seeing changes by cardiac MRI. What's the treatment for patients that have MISC? Well, it's actually very similar to what we how we treat Kawasaki's disease. They got IVIG, and steroids were relatively common. But this study that was published in the New England Journal of Medicine, which is the largest study we have to date, they mentioned that understanding the pathogenesis of MISC will be necessary to inform clinical management and prevention efforts. The study was not designed to evaluate or to compare long-term effectiveness of any therapies. The treatment methods must be informed by whether the organ damage is mediated by the ongoing viral replication, in which case something like remdesivir would be more effective, versus exuberant host inflammatory response, in which in case of monoclonal antibodies may be more effective. So shifting gears, let's look at the, let's see if I check my time here. Look at the effects of myocarditis on the heart. And this came out in early September. This doctor in Penn State said, well, you know what, we're seeing COVID effects in the heart in 30 to 35% of our athletes. And this created a huge scare, as you might imagine. They said of the COVID positive athletes, 30 to 35% of their heart muscles were inflamed. It turned out that this was actually later found to be a poorly done study, but it created a lot of concern in the world of athletics. And then there's been 2 COVID-related deaths that we know of thus far. This was a basketball player that had played basketball in the SEC conference, I think, and then actually went over to Europe to play, and he actually ended up dying from myocarditis, presumed myocarditis. He had a COVID infection and subsequently had what they said was a heart attack, which was probably a cardiac arrest. So why are we concerned about myocarditis? Well, if you look at sudden cardiac death in athletes, the question is, what is the main cause of death? The most common cause is hypertrophic cardiomyopathy. The second most common cause, about 20%, is commotio cordis, which is a sudden blow to the chest that causes an arrhythmia. It's blood trauma to the chest that hits at the right time and triggers an arrhythmia. Coronary artery abnormalities are here. Here's left ventricular hypertrophy of indeterminate cause, which is probably hypertrophic cardiomyopathy. These were all primarily diagnosed by autopsy. But here's myocarditis. And if you look at the number of athletes that die each year, it's probably around 100 per year, which means about 5 athletes' deaths each year are contributed to, we say 5 to 10 are contributed to myocarditis. And so when we saw this concerns of myocarditis or myocardial inflammation in athletes, and we know that as a cause of death in athletes, there was a high level of concern. So then they said, we better figure out how we're going to determine when they can go back to play if they've had a COVID infection. So this was a study, or an algorithm, not a study, but an algorithm published in early August, looking at if you're COVID negative versus COVID positive. And then they break it down if you're asymptomatic, if you have mild symptoms, or if you have significant symptoms. And if you have mild symptoms, they said, you should probably check a troponin, a 12 EKG, an echo, and consider additional studies. This is with mild symptoms, not hospitalized. Now, one of the things I want to point out, and I'm sure we'll all remember, is we're going to check a troponin, right? Well, when do we check troponins? We're going to check a troponin after they clear isolation. We're not going to go into their house on day 1 or day 2 when they've been tested and tested positive to check it. So we're going to check a troponin 7 to 10 days later, or 10 to 14 days later. So here we're checking a troponin over here. This is like getting a pregnancy test after the baby's delivered. The odds of getting a positive test at that time are pretty low. So, but they say, well, let's check it to see if it's abnormal. We'll check an EKG. Once again, an EKG may show changes that are not related to COVID, but may be related to being an athlete. You get an echo that may show some artery enlargement that may be normal for an athlete, and then you consider additional changes. If you have significant changes, you have to undergo the full protocol. Now, this has been an evolving process. So if you have significant disease, I don't want to point out, though, you follow the myocarditis guidelines. I'm going to show you what the myocarditis guidelines are. So if there are concerns of an elevated troponin, you have to think about myocarditis. So because of these concerns, in September 11th, there was a study published, this was out of Ohio State University, where is actually a letter in JAMA. And what they did is they did cardiac MRIs on their NCAA athletes that had COVID infections. And what they found was that 15% had MRI findings suggestive myocarditis, and 31% had late gadolinium enhancement with T2 elevation, suggesting myocardial injury. So they said, to conclude, a cardiac MRI may provide an excellent risk of stratification assessment for myocarditis in athletes who have recovered from COVID infections to guide safe competitive sports participation. So what the study didn't include was, it didn't include any controls. The German study had controls and said, okay, what's the rate of abnormal cardiac MRIs in a control population? The control population here should be athletes who don't have COVID infections, because we know if the troponin is elevated in athletes, it's quite possible they may have some myocardial changes. You know, if you get a cardiac MRI in someone who just underwent a vigorous football practice or rowing practice the day before, they may have some changes. We don't have that control group. But they said, you know what, we better think about getting cardiac MRIs from these athletes. And then not long after that, this is 4 days later, a bunch of radiologists and imaging specialists said, whoa, you're overstepping your bounds here. And they basically said, we're a group of clinicians, researchers, imaging specialists concerned about the presentation, interpretation, and media coverage of the role of cardiac MRI in the management of asymptomatic COVID patients recovered from COVID-19. In the light of our society's standing in the community and advocacy against low-yield testing and low-value medical care, we request that you offer clear guidance discouraging cardiac MRI screening for COVID-19 related heart abnormalities in asymptomatic members of the general public. So here you have these two diametrically opposed recommendations. One is, if you're an athlete, you've got COVID, get a cardiac MRI, and this society is saying, wait a minute, that's not good use of our medical resources. So let's keep on going through the recommendations. Here's another one that came out for pediatrics, not for college athletes. And they said they use a cutoff of 12 years of age. And they said, if you're under 12 years of age, you had COVID, don't worry about it, you can participate. Now, of course, this assumption here is that they're not doing vigorous activity, but if you're a Chinese gymnast, you probably need to get an evaluation. If you're over the age of 12, they said if you have high intensity competition, get an EKG prior to participation. If it's normal, you're cleared. If it's abnormal, you're not. This was one guideline that came out, this is probably about early August too. If you have severe symptoms, you got to do more testing. The American Academy of Pediatrics, here's their guidelines, and they said that those with moderate symptoms may return to play if they're asymptomatic for 14 days and obtain clearance from their primary care provider. They recommend an EKG for possible referral to pediatric cardiology if they had positive cardiac symptoms or concerning findings on exam or moderate symptoms. So once again, they're just recommending an EKG if there's any concerns of cardiac symptoms, but not on everybody. And this is South Dakota's guidelines. They just pulled these up last night, so this is fairly recent. In South Dakota, it's any participant with a verified positive case must satisfy the following requirements. They have to have their 14 days have passed since their onset of symptoms. They have to be asymptomatic for at least 7 days, but they can return to play after an approved healthcare provider evaluates them. So no cardiac testing is required in South Dakota. And then another algorithm just came out. This just came out in JAC as of this month, and they use a cutoff of 15 years of age. And if you're asymptomatic and have mild symptoms, cardiac testing is not required. And once again, this is a proposal. These are not, established guidelines. If you have moderate symptoms, severe symptoms, you can consider cardiac risk stratification with an EKG, high sensitivity troponin, and echocardiogram. And then what happens is based upon the results. If you're over the age of 15, not under the age, but over the age of 15, remember the other cutoff was 12, but over the age of 15, you follow the return to play guidelines for college athletes, and we'll go down to show you what that is. So this is if you're a college athlete. If you're asymptomatic, mild symptoms, you can return to play in a graded escalation based upon your activities. Maybe, of course, you're isolated during your post-exposure time period, but no cardiac testing. It's unnecessary. If you have moderate symptoms, you have to undergo a cardiac evaluation, including an EKG, high sensitivity troponin, echocardiogram. Once again, we're doing this testing, especially the troponin, after they've already had their inflammatory process, if it was present. And if you have severe symptoms, during hospitalization, you have to get to troponin cardiac imaging, and they're going to go down that myocarditis guideline. So once again, markedly discrepant recommendations across organizations and across the timeline. Now, let's say you do have myocarditis, signs of myocarditis, and this is basically primarily based upon an elevated troponin. We have not used a cardiac MRI as a determinant of myocarditis per se. If you have these elevated troponin, you are restricted from athletics for 3 to 6 months. So you can see this is a big deal. If you have a football player that has an elevated troponin in the Big Ten, you're out for the season. And then you have to, in order to return, you have to go through clearance, and which is what we have going on down here, what the evaluation is. So what has the Big Ten decided to do to get athletes playing? And the Big Ten is the most restrictive conference in the Power Five. They're saying all COVID-19 positive athletes have to undergo biomarkers, which is your troponin, and EKG, echocardiogram, and cardiac MRI. So if you're positive, and this took effect September 16th, if after September 16th, if you have a positive test, you have all these tests done. And I know this because I'm the cardiologist that is tasked with clearing all the athletes at Iowa. And they have the typical initial isolation period, but the earliest an athlete can return to competition is 21 days after you've had a positive COVID infection. They classify sports differently. And when you think of high contact sports, we think of butting heads. But in here, high contact sports are rowing and water polo and wrestling, because these are sports where you are likely to spread the virus because you're in close contact with the patient for extended periods of time. Low contact, golf, fencing, riflery, swimming, diving. So they break down their testing protocol upon whether you're high contact or low contact. In football, we are testing every day. And thus far in Iowa, we've performed, as of, and every Monday I meet with the other Big Ten cardiologists. We have a phone conference. We've done more than 60,000 antigen tests thus far to evaluate the athletes, because once again, they're tested every day. Each school has 170 tests for their football program, 120 for the athletes, 50 for the coaching staff. And they're tested every day. Some schools, you can take Sundays off, but most schools are tested every day. So what happens in the Big Ten is first you educate the players so they don't get exposed. If they're identified by an antigen test, a rapid antigen, they get a confirmatory PCR. They're placed in isolation. Then you do the evaluation. The evaluation includes a troponin, an EKG, an echo, and cardiac MRI. All this data gets put into a Big Ten registry, and the data is adjudicated at this level, which is, when adjudicated means it's verified. After you evaluate them, you go through a management strategy. They're asked to return to, or they're recommended they can return to play. It's a 7-day ramp up after 14 days of isolation and rest. We redo the education, and then they get symptoms. If they get symptoms again, or they have a positive test, they go right back to this. So we've had patients that had positive COVID tests back in June that didn't require this, and then they get retested in September 20th, they're positive, they go through this whole protocol again, which probably doesn't make sense, right? So my proposal is that we reevaluate this process and say, okay, do we really need to retest all these athletes that were positive once in June and then positive again? And the other question I would have is, maybe we need to start doing some of this testing during their isolation period. Now, this is a big proposal because who wants to go into person's room that's positive and draw their blood? But this would probably give us better data to evaluate whether these tests are effective. So what are the take-home points here? I think I'm on schedule here. Number one, COVID-19 can affect the heart due to multiple different mechanisms. There's a type 1 and type 2 myocardial infarction. There's a stress of just having the COVID infection. troponin is an important biomarker, and it's associated with a worse prognosis. Cardiac injury can persist after symptoms resolution, and the longitudinal follow-up is required. And we talk about these long haulers that have disease. You know, that study done out of Germany, where more than 2 months later they're still seeing cardiac involvement. Now that was in an older population, but that was concerning. Fortunately, in pediatrics, cardiac involvement is much less common and death is rare. Multi-inflammatory syndrome in children is more prevalent, and it's similar to, but not the same as Kawasaki's. The treatment for COVID-related disease is evolving. So when I say COVID-related disease, it's COVID-related cardiac disease. We're getting a better handle on how we treat the pulmonary disease, but the cardiac disease is still evolving. And as we pointed out, the return to play recommendations are a moving target. The significant myocardial injury warrants restriction for obvious reasons. You know, we don't want a myocardial infarction or a sudden cardiac arrest following a COVID infection. And there's much to learn. So I'm going to open up for questions, but one of the questions is going to be probably, what would I recommend for athletes? And I would say this most recent proposal that's written up in the Journal of American College of Cardiology is a pretty good recommendation. If you have your asymptomatic or mild symptoms, it's probably okay to go back to sports, but just keep a close eye on them. And I counsel even the patients that I see in clinic that have cleared, the athletes at the University of Iowa, I tell them, you've been cleared, but that doesn't mean you're out of the woods. And if you get chest pain, if you get palpitations, if you feel like you're not getting back to where you need to be or where you should be, we need to reevaluate you, because we don't want to have one of these patients. As an example, in Penn State, at Maryland, there was an athlete that had been cleared, had a COVID infection, had been cleared through the testing. 5 weeks later, he presented with chest pain and had a significant pericarditis and myocarditis. So that's 5 weeks later. Now, those cases I think are going to be rare, but just because you get cleared early on doesn't mean you're out of the woods. And with that, I'll open it up for questions. Let me just see if I can get this to be full screen here. I need to, if there's a chat, I'll make this big here. If there's a chat room, I'm not seeing it, so. Nope, no, nothing in the chat. Any questions?
Ian, Nofil here. Hey, great talk. Thank you so much. A quick question was, you know, when you were talking about the risk factors in kids for MISC, I think mostly that's been kind of shown is probably obesity, perhaps questionable lung disease. What about cardiac disease, you know, kind of more specifically, you know, Fontanes and kids with underlying heart failure at baseline?
Yeah, this is one of the things I found surprising, and I'm sure Nofil and Teresa and Bill, you guys have taught your colleagues. We have not had an overwhelming number of our cardiac kids require hospitalization for COVID infections. As a matter of fact, we've had several Fontanes that had COVID infections that we just monitored at home. So, and I've talked to my colleagues at Michigan and across the country, and we've not seen a lot of now this is knock on wood because we're entering another surge here. So, but we've been very fortunate, and I don't know, have you had many hospitalizations in Sanford?
No, fortunately, you know, again, knock on wood, it's kind of been the same. I think we've had a few cases of kids with chronic cardiac conditions who have tested positive or at least have had close contacts, but they've managed to stay home so far.
Yeah, and I think that's been one of the surprising findings. And actually, you know, early on, I think we were all very worried. But fortunately, that has not panned out. So that's been reassuring. There's a question about any studies on patients with previous Kawasaki disease and now get COVID, or they're higher risk, almost like along the lines of if you have a rheumatic heart disease from a strep infection, are you more at risk for the second time you get a strep infection? I've not seen anything yet, and I guess you can talk to your infectious disease doctors, rheumatologists. It's a good question. You know, because they had such a profound inflammatory response early on, one would suspect maybe they'll have another profound inflammatory response after they get a COVID infection, but I've not seen any data along those lines. Next one is, do we know what percentage of children with COVID positive disease have some cardiac involvement? You know, the problem is, of course, you know, more than 40% of children have symptoms, and so we don't have a good handle on those that were asymptomatic because they never presented. The cardiac involvement, we think in pediatrics, is very low, but we don't have that number. It's a good question. You know, if you looked at the adults that were asymptomatic or didn't require hospitalization, they still had a fairly high cardiac involvement rate. We've not seen that in pediatrics, but it's not been well studied. Any other questions? And
Hi, Dr. Law. This is Susie Reuter from the NICU. We're not seeing much COVID in our babies, but thank you for all your help with the electrophysiology in our babies. And that was a great presentation. One thing that I'm interested in knowing, how often are you seeing in the college athletes, you know, after they're better and they've recovered from their infection, are they just presenting with like symptoms of fatigue, not necessarily overt cardiac abnormalities, but maybe just some fatigue?
Yeah, it's so I think we've evaluated, we've done 43 cardiac MRIs thus far. We've only seen myocardial changes that would suggest myocarditis in a couple. We picked up two patients that had LV non-compaction. I also picked up a patient that had Wolff-Parkinson-White syndrome on EKG. But we have seen these patients that have had fatigue. And the question is, you know, an athlete that has been in isolation for 2 weeks and they say, boy, I can't do what I used to be able to do. I'm thinking, well, you've been doing nothing for 2 weeks. And some of these people really just do nothing. I think they sit and watch Oprah all day long because they just enjoy the time off. But I believe it. So it's hard to say whether their fatigue is because they can't get back to where they were before, or are they truly have an effect from the COVID. We have seen, I think, some long haulers where they've had the respiratory issues, I think, are more prevalent, where they get more short of breath much sooner than they would think. But I've not seen true cardiac changes. Now, all these patients that come in with respiratory concerns or shortness of breath, they're getting a full cardiac evaluation anyway. But I have seen a number of patients that have that fatigue, and we're still trying to tease out whether it's true shortness of breath, cardiac disease, or just because they're deconditioned. I've been doing a lot of cardiometabolic treadmill tests, and I've had some patients that say, I'm just incredibly out of shape, and I put them on the treadmill, and their VO2 max, which is an indicator of cardiorespiratory fitness, is just sky high. I mean, it just crushes people. I'm like, well, what you think is out of shape and what we think is out of shape are two different things. And then, of course, they get back to the activity and they feel fine. So,
yeah, okay, awesome. Thank you very much.
I see that Bill Waltz actually watched it on in his deer stand, so he's a real trooper. Any other questions? Yeah, this testing of athletes has been very interesting across the Big Ten, and you know what you realize is that we were very fortunate at Iowa. You've seen our football games where the Children's Hospital, and the hospital's right next to the football stadium, but like in Penn State, you know, Happy Valley is not near a hospital, so all their athletes have to get put on a bus and shipped over to get their cardiac MRIs. And as of a couple of weeks ago, there are several Big Ten institutions that had not had any cardiac MRIs done. So they were unable to get their patients back, or their athletes back on the field, because they had not done the cardiac MRIs. We've been fairly fortunate. One of the things early on, as you might imagine, was insurance companies paying for these cardiac MRIs. Their indications, question is, why are you doing this? And you saw the letter from the imaging specialist saying we don't need to be doing this. But I think athletes are a little bit more unique because we put them under a lot of stress. And so if they get COVID, they may be at a higher risk of inflammatory process. Oh, they did talk to one softball player. I said, where do you think you are as far as your overall fitness? And, are you 90% back being in shape? And she goes, I play softball. I don't have to be in shape. I'm like, I bet you do have to be in shape. Pete's ID here are both acute renal failure and Kawasaki disease, as both acute renal failure and Kawasaki disease are rare conditions. I haven't come across reports presenting with COVID and renal failure. I would expect any case report as it develops. Yeah, I've looking at that. I have to pull up that study looking at out of the New England Journal of Medicine to see what renal involvement was. Obviously, I focused on the heart, not the kidney. So there might be some data there to look at that. It's a good question. And as I scan the literature, I'm really focusing on cardiac literature, not the renal kidney disease. So I'm probably not the best person to answer that question.
Yeah, I wonder if you meant rheumatic fever.
Oh, rheumatic fever. No.
I typed the comment, Fernando Bula, Pete's ID. Sorry, yeah, I tapped the comment because I had like some noise background, but yeah, I meant the both rheumatic fever and Kawasaki disease. Sorry. Yep. Okay. One lesson there to not use the acronyms because it can mean things. But yeah, I mean, I would say like a double, double whammy. We have probably in our patient population ID 2 patients right now with acute rheumatic fever that we follow. So and then of course the questions came from the parents, like, what is the risk of my kid, since one of the kids has the carditis. That's how diagnosed the acute rheumatic fever. And so, well, so far I know the kid has not presented with COVID. They come to get the penicillin shot every month. And so I told the mom, well, if you get tested and positive, just let us know and we'll see what happens there. But overall, nationwide, no reports with the 2 or with like Kawasaki. So I think as the winter develops and the second or the persistent wave of COVID in the US, we'll see what data we have.
Yeah, one would suspect that you could be at a higher risk. I mean, obviously, why are kids thus far having such a lower fatality rate, mortality rate? Obviously, there's a question about the ACE2 receptors. Is it cross-reactivity with the other coronaviruses that are out there? Is it just this difference in immune response? It's a very interesting question, but fortunately in pediatrics, we've been spared the brunt of the disease burden. Anything else? As I said, I'm happy to share the slide deck if you have, I can pass it on to Angie if people want to see those recommendations.
That'd be great. Thank you so much, Ian.
Okay. No fault. I might put you in charge of that.
Sure.
And Angie, but you'll be on the cardiac side. Okay. Well, I think rather than just stare at each other, I think we can go.
Thank you.
Thank you.
Thank you so much. It was a pleasure.